Okay, so thank you very much to give me the opportunity to present our study, so titled Antibody Response to SARS-CoV-2 Vaccination, and it is extremely vivacious in subjects with previous SARS-CoV-2 infections. And I'm working in Papa Giovanni Hospital, as a general hospital in Bergamo, a town in the northern part of Italy, in the region Lombardy, that faced for first the pandemics, the COVID-19 and pandemics. And the town is also sadly known for his high mortality rate, has, as you know, all around the world. So we can move to the background, and as we know, so now
sorry for the interruption, doctor. Your voice is not a bit clear.
What is not clear? My audio?
Yeah, your audio is not clear.
It's not clear. It's better now. It's better now. Okay.
Yeah, it's good.
Sorry. Okay, I'll try to speak with higher voice. So we know that the pandemic is now.
Hello, doctor. Is it possible to read the mask, if you don't mind?
So we know that the pandemic calls for rapid actions, and particularly oriented to a worldwide vaccination campaign. Can you hear me now?
Yeah, it's clear now, doctor. Go ahead.
Okay. And so we know also that now two mRNA vaccines are available for the massive vaccination, so all around the world. And we know also that both phase 3 trials on these vaccines reported high efficacy in preventing symptomatic SARS-CoV-2 infections after 2 doses of the vaccines that have been administered 3-4 weeks apart in subjects without previous SARS-CoV-2 infections, as reported by the registrative studies in New England Journal of Medicine. So, but however, little is known about subjects with the previous exposure to SARS-CoV-2 infections. We know that anecdotally, individuals with pre-existing immunity experience more severe reactogenicity after the first doses compared to naive individuals. And the vaccination campaign in Italy started at the beginning of 2021. So in January, with the health workers using Pfizer vaccine. That was the only available vaccine at that time in Italy. And the aim of our study was to verify an hypothesis that if in individuals with a previous SARS-CoV-2 infection, both disease or asymptomatic patients, a single administration of Pfizer-BioNTech vaccine could elicit an immunological response superimposable to a full vaccine schedule in naive individuals. And we start from the assume that for individuals with individuals who experienced in a SARS-CoV-2 infection, the first vaccine dose could immunologically resemble the booster dose in naive individuals. Here we can see the study design. In this table, you can see so considering the vaccination schedule and the time between the 2 doses, that was and that is 21 days. So we divided 2 groups, and the first one was made by individuals with previous SARS-CoV-2 infection, and the second one was made by SARS-CoV-2 naive individuals. And regarding the sampling for antibody quantification, we define two kinds of sample, and a sample just before the second vaccine dose and between 7-10 days after the second vaccine dose for individuals with previous SARS-CoV-2 infections, and only one antibody quantification between 7-10 days after the second vaccine dose for naive, so individuals. So what about the antibody test? We used a test that recognized antibodies against SARS-CoV-2 in serum samples, and by Alexis anti-SARS-CoV-2 S immunoassay that acts against SARS-CoV-2 spike protein, and particularly RBD, so receptor binding domain. And we tested 184 serum samples, and these samples, those samples were determined with a cutoff limit of 0.8 unit per ml, and the values above the measurement range were quantified using the recommended diluent universal on cobas E602 analyzers. And the specific unit per ml of the antibodies quantification test can be considered equivalent to the binding antibody units of the first WHO international standards that was ready at the beginning of 2021 for anti-SARS-CoV-2 immunoglobulin. So moving to the results, we can see here in this picture the cohort characteristics of the three subgroups of our cohort, of our study. And overall, you can see how the number of enrolled subjects was 110 for SARS-CoV-2 naive subjects, and 74 the subjects who experienced a SARS-CoV-2 infection or COVID-19, and the majority of the majority was of feminine gender, with a percentage of 68, and the median age also overall was 50, with an IQR of 39 and 3956. And the infections of asymptomatic individuals was previously recognized by a positive nasal swab or an serological test. In May 2020, in our hospital, we made a massive serological test for all the health workers in our hospital, exactly. So we can see also here the antibody response to mRNA vaccine, Pfizer vaccine, in terms of median titer, and we can see the four groups of individuals, and the quantification of the antibody, the total antibody, in terms of unit per ml. You can see the median titer here in this slide. And you can see also that there is a statistically significant difference between the group of SARS-CoV-2 naive individuals and the group and the two groups of individuals who experience a SARS-CoV-2 infections, asymptomatic or symptomatic, and you can see that both results were far above the median titer in naive individuals after a full vaccination schedule. And here you can see also the antibody response to COVID-19 vaccines in pre-exposed subjects after the first and or the second dose. And also in this case, you can see that there is a statistically significant difference. So in terms of time effect, in pre-exposed individuals, titer were slightly higher in subjects who acquired the infections during the first wave. So you can see here the time from the infections in terms of days. So the titer was slightly higher in subjects who acquired the infection during the first wave, observed in March, April 2020. So 11 months before testing, compared to those with more recent infections, particularly 2-3 months. In this case, we don't have a definitive answer to this. I thought it might be because there were more cases of severe infection or disease in this first wave here in Bergamo and in Italy too. So we reported also the most frequent adverse events after the vaccine injection, separated by first dose and second dose in the 4 subgroups, and regarding fever, pain, asthenia, weakness, headache, and muscle joint pain, and so on. So you can see the most frequent adverse events were pain and asthenia and muscle joint and fever in a few cases. And adverse events, so we can see that adverse events were also so adverse events after vaccine injection were more frequent after the second dose of vaccine overall, and adverse events were also less frequent in naive compared to exposed individual with previous SARS-CoV-2 infection. So what about the results and what about discussion and conclusions of our work? So a worldwide vaccination campaign, we know that is an expensive, time and labor consuming effort. And so eventually we can consider a single vaccine dose in subjects previously exposed to SARS-CoV-2, and it would offer advantages in terms of costs, timing, and possibility to reach a greater number of subjects in a shorter period of time. So our findings suggest that a single dose of the mRNA vaccine elicits a very strong immune response in seropositive individuals with a post-dose antibody titers tenfold higher to those observed in naive subjects with a full vaccination schedule. And these observations are in line with the hypothesis that the first vaccine dose served as a boost in naturally infected individuals. So our study has some limitation because it has been conducted in healthcare workers, so the age of enrolled individuals range from 24 to 26 years. And so we cannot exclude that younger or older subjects could react differently in this case. And all our subjects were Caucasian, obviously, and we therefore cannot extend observation to different ethnicity. In our experience, all patients but too with pre-exposure to SARS-CoV-2 showed antibody titers well above the 1,000 ml after a single vaccine dose. And this finding appears reassuring in light of the differentiated vaccination schedule. And finally, in SARS-CoV-2 naturally infected individuals, we can say that a single mRNA vaccine dose seems sufficient to reach immunity. And so modifying currently implemented dosing schedules would speed up vaccination campaigns and could limit occurrence of adverse events in this subgroup of individuals. So thank you for your attention. And if you have any questions, I'm here. Thank you.
Doctor, there is a question for you in the chat box. Please have a look. Hello, doctor. Do I repeat the question for you?
Sorry, but yes. People who are symptomatic or have infected. So I tried to answer to the question of Juan Carlos Vasquez Chagoyan the first, and what my feeling about your questions. I don't know, but if I see only my results, but not only my results, but also other results of other groups that confirm our findings, probably I'm not at the moment agree with this statement. So the statement of the third vaccination, so the third dose. But we don't know a lot about the duration time of this immunological response, and what about also the T-cell immunity, so the T-cell response. So I think that we have to do a longitudinal study to compare these results with the new results from the same people from the same cohort during the time, probably after 6 or 8 months, the first test. And sorry, I don't understand the Helen Banoun question. Could you explain better your question?
Can I speak? It has been shown that people asymptomatic or with mild COVID didn't had antibodies, detectable antibodies, especially anti-spike antibodies.
Yes.
They have.
Yes.
All, so
okay.
Perhaps you didn't detect these individuals, and you thought it was naive, but they have been infected.
Yes, it's possible, but I say you that in our cohort, all the individuals responded to the vaccination. So we detected a antibody titer for every one of the enrolled individuals in our study. So probably your question is, so you prefer a neutralizing antibodies test. This is your question, to test the vaccination response. This is your question, or because because this kind of antibiotic, this kind of antibody are not neutralizing antibody, and so I think that you prefer to use a neutralizing antibody. This is your no.
Excuse me, I didn't understand. My oral English is very bad. I have published a preprint review of immunologic cross-reactivity toward human coronaviruses and SARS-CoV-2, and
Yes.
they showed that some people have been infected by COVID, but they didn't develop specific antibodies to spike because they fight the virus with cross-reactivity with human coronaviruses. So they were infected, but they didn't develop antibodies anti-spike. So perhaps when you tested individuals, you had persons who were infected but has no antibodies, and you consider them as naive individuals. That's my question.
Yes, you are right, but in our court, we didn't see what you are saying. So in our court, all individuals have an antibody titers for SARS-CoV-2 infection. And probably another point is that we had to investigate not only the antibody titers, but also the T-cell immunity, because probably the T-cell immunity will show us more details about the response to the vaccine.
Yes, of course. T-cell immunity is very important. Yes, thank you.